So you received an audit. What happens now? Welcome to a pre-course review on the audit process. My name is Tracy Gaunt and I'm one of the professional standards specialists for the Southwest Ontario Regional Base Hospital program. The objectives of this review are to describe the purpose and process of an audit and investigation, describe the various audit categories, and review a sample ACR. The purpose of the audit is mainly for number 1, public safety, number 2, to meet compliance with the College of Physicians requirements, number 3, compliance with the Ambulance Act, Regulation Part 4, Section 11 and 11.1, meet compliance with the Ministry of Health Long-Term Care Performance Agreement, and it also provides an independent review mechanism for us. The secondary purposes of an audit are, for 1, advisory, it's best practice feedback to give to the medic, medical advice to the Ministry of Health and Long-Term Care and to the service operators. Number 2, it's for educational purposes. And 3, it provides data for research for all. Data collected, as you can see in this graph, can help us focus on how we develop our research based on variances, along with monitoring existing performances, internal and externally. So let's take a look at the audit process. The audit process is actually defined by our policy, which can be found on our website under Policies and Procedures. It's defined by computer algorithms that help identify high-risk cases for audits by human. It's done by trained peer reviewers identifying possible deviations. The local medical director and professional standards specialist will review each of these deviations to determine if an investigation is required. Auditing. So an audit is pre-screened by our professional standards coordinator. All calls are generated back from an automatic system that are logged and then reviewed by an assigned auditor. A percentage of the various types of calls are audited for quality and assurance purposes. We audit 100% of all VSAs, it's done manually. We audit 20% of no service calls, which is also done as a manual audit. The audit process. Audits are filtered through various forms internally through the audit process, as described earlier. Can also be done through the educator. Externally, a service operator can identify an ACR that needs reviewing, as well as the hospital can request that an ACR be audited. The paramedic can choose to self-report an ACR that has a possible variance. All of these are filtered into the local medical director for review. The self-report process. Self-reporting allows the audit process to potentially move quicker through the process than calls identified through a complaint or audit. Although it's not considered a protective dome when self-reporting, it does turn a stressful situation into a professional practice learning experience for the paramedic. The investigation process. Each LMD is assigned an investigator. The investigation will follow stages, and at each stage the LMD reviews the process and the progress, and then will decide if A, more information is required from the paramedics, if education is required, if the case can be closed, or if a deactivation is required. Investigation process. To facilitate prompt action, requests for written responses are sent via email with a 2-week request for responding. If a paramedic does not respond in that 2-week time frame, another reminder is sent with another 2-week request response. Failing to do so, a final reminder is sent to the paramedic via email. Noticing a resultant deactivation can occur if the issue is not addressed. Following no response after that 45 days, a clinical deactivation can occur for not responding to a request for a response. Investigation process. The investigator and LMD will reconvene when outcome parameters have been satisfied. On closure, the local medical director makes a determination of the potential for patient impact, and a closure letter is sent to the paramedic. An annual report, classified as the SOAR, Summary of Activity Report, is specific to each paramedic, and they will have this record to allow for reflection during their recertification time. These reports do remain on the paramedic's file. Audit follow-up. The request for a written response comes from the medical director. The written response will help assist in understanding the thought process of the medic during the call and helps to create a clearer picture. A BLS-only comment on an audit represents a deviation from the BLS standards or the ACR documentation standards. These are referred to the service operator for follow-up. An audit with a none with comments attached to it notes that there are no errors on the form or during the call, but is used as an opportunity to add comments that may reflect best practices or options for the paramedic's consideration. Minor. Let's look at the definitions of what a minor, major, or critical classification on an audit would be considered. A minor omission or commission is defined as an action or lack of action by the paramedic that did not have any direct effect on patient morbidity. However, it may have affected patient care in a minor way. An example of that would be a paramedic does not obtain a blood pressure as part of a full set of vitals before administering Ventolin. Major. A major omission or commission is defined as an action or lack of action by the paramedic that has affected or the potential to affect patient morbidity. However, the outcome would not be considered life-threatening. An example of this would be a paramedic who administered oral glucose gel to a patient with a blood sugar of 2 and a GCS of 13, but did not administer glucagon or dextrose. Critical. A critical omission or commission is defined as the performance of a controlled act or acts for which they have not been certified, or an action or lack of action by the paramedic that has a clear effect on patient morbidity with a potentially life-threatening outcome. An example of that would be a PCP who does a carotid massage on a patient in SVT, or an ACP who defibrillates an SVT instead of using cardioversion. Summary. So to summarize the audit classification, a minor did not make the patient worse, a major had the potential to make things worse, or did make things worse but was not considered life-threatening, and a critical is considered life-threatening. Self-reporting. Paramedics must make every effort to immediately inform the receiving physician of the protocol variance and any potential complications that may arise from that variance. Self-reporting. Upon recognizing a potential omission or commission, the paramedic will have the option to self-report immediately via the telephone, the self-report hotline number 1-888-997-6718, or via the self-report email, selfreport, all one word, at lhsc.on.ca. Self-report information. When self-reporting via hotline or via email, we ask that you provide the following information: your name, the service you are currently working for during that call, the run number of the call in question, the date and approximate time of the call, a brief description of the omission or commission that you're reporting, the hospital the patient was transported to, and any known adverse effects experienced by the patient that you are aware of. Self-report the facts. So does a self-report really work? Well, most self-reported cases are reviewed and completed within a 24-hour period, case dependent. Paramedics realize the omission commission and provide their own self-review or study. It's proven to be the most effective tool in education and remediation than an unreported incident waiting to be discovered. It benefits a paramedic with a well-rounded education and support structure to assist in reviewing the case. Sample ACR. Let's look at a sample ACR that has a potential omission or commission. So it's a 17-year-old, history of asthma, developed respiratory distress, and then goes unconscious. Upon EMS arrival, bystanders are performing CPR. Patient is cyanotic with agonal respirations, with a palpable pulse. Family members state the patient has had severe asthma attacks in the past. So looking at the past history, we have asthma. Patient has a history of taking Ventolin. No allergies. CPR is in progress by an off-duty police officer. Patient's lying on the floor unconscious with agonal respirations. Limited air movement and wheezes throughout. Sample ACR continued. Let's continue on with our sample ACR, the 17-year-old patient with a history of asthma who's VSA. Upon crew arrival, the patient is a CTAS 1. Patient has adult pads applied, oral airway inserted, resuscitation done via BVM. Patient has one analysis performed with a no shock advised. Patient then has a documented heart rate of 135 with noted palpable radial pulse and a blood pressure of 186 on 114. The crew then administers epinephrine, 0.5 milligrams IM, are unsuccessful with their IV attempt. They load the patient onto a spinal board and get ready for transport. During transport, patient appears to go VSA. CPR is initiated again, and CPR continued throughout the call until arrival to the hospital. Sample ACR continued. Let's continue with our sample ACR, our 17-year-old patient who is VSA with a history of asthma. In the remarks section of the ACR, the paramedic noted the decision to transport after the patient went VSA without additional analysis was due to the fact that the patient had a very obvious ECG rhythm throughout the call. It is clear that the additional time required to stop the ambulance and perform an analysis would not have benefited the patient. They also note that firefighters accompanied the crew, assisting with ventilations and CPR en route. Sample ACR quiz. So reviewing the sample ACR regarding the 17-year-old VSA with a history of asthma, let's take a quick quiz. Question 1. The deviation from standard would be A, documentation oversight, B, related to the administration of epinephrine, C, related to the interval between analysis, or D, related to having insufficient CPR notation. The answer to that would be B, related to the administration of epinephrine. Moving to quiz number 2, the potential deviation would be considered then A, critical, B, major, C, minor, or D, none. The answer to that would be A, critical. Questions. We hope you enjoyed this review of the audit process. If you have any questions regarding the audit process or this review, please do not hesitate to contact one of the regional paramedic educators. Once again, thank you.